A little bit about this presentation. All participants will be muted during the presentation. When the presenter finishes, we will open up for questions and answers. You are welcome to submit questions during the presentation through the question pane in your control panel on your screen. When asking questions, though, please remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. We will be recording this webinar, and it will be available on the SHARE website soon. Now I want to introduce our speaker. Dr. Markman is a nationally renowned oncologist with a focus on patient-centered care. He is president of the Medicine and Science Center at Cancer Treatment Centers of America. Sorry, just one moment. And he has also more than 20 years of experience and leadership in cancer treatment and gynecologic research at some of the country's most recognized facilities, including MD Anderson Cancer Center at the University of Texas, Memorial Sloan Kettering Cancer Center in New York, and Taussig, I probably said that wrong, Cancer Center at the Cleveland Clinic Foundation. I'm going to turn it over to Dr. Markman. Thank you so much.
Thank you very much. It's a pleasure to have the opportunity to speak on a very important, a very topical, and I think to some who are listening, a very personal part of the journey of cancer in general and ovarian cancer in particular. What I'm going to do over the next few minutes is sort of divide my comments into several parts. First is to talk a little bit about why immunotherapy and why it has the appeal it does, a little bit about the historical context. Then give a sort of an overview of the various kinds of approaches to immunotherapy in general as relates to the field of cancer medicine. And then specifically to comment on where we are with that more general topic in the management of ovarian cancer. And finally, and I'll make this point at the end, but I'll say it now, my last slide, my last few comments will be a very personal commentary that will step away from the data, but my comments about my personal opinion on how we need to move forward. So I really want to acknowledge what I'm going to focus on is data, evidence, but at the end I'm going to step away from that and say, my own opinion about how we might optimally move forward. And again, I want to distinguish data from opinion, which is what I'll be voicing at the end. So immunotherapy, immunology is an incredibly interesting topic as relates to cancer. And to step back for a moment, for those of you who are listening who are cancer patients, cancer survivors yourselves, or loved ones of cancer patients or cancer survivors, you know firsthand, personally, or friends of those individuals, I want to say, the loved ones, people that are close to you. You know personally what the word cancer means and what it does, and that's the fear, the unknown, and I won't go any further than that, except to say when that diagnosis is given, then there are natural feelings that come up. And in addition to the feelings of grave concern and what does it mean and what's going to happen, there is another feeling, a very positive feeling, a very important feeling, which is, what can I do? What can I personally do to deal with this, to live with this, to cure it? And as part of that general conversation of what can I do, one turns to that which is in oneself. And I'm not talking about questions of the more general questions of obviously support and emotional support, and all of that's really important, and nutrition all really important. I'm really talking about when one begins to think, what can I do to my own body or through my own body? What can I do to help the natural, the innate, even God-given, if you want to use that term, part of me that could fight this, that by the way fights off infections and allowed me to recover from trauma, that accident that I had 10 years ago when I had a broken bone and healed. What can I do to help stimulate that part of my body, which we often use that general term of the immune system, to rid myself, or if you're the loved one, help my loved one rid themselves, in addition to chemotherapy, radiation, surgery, etc. But that part of me that can help with that, again, loosely termed the immune system. And so there has been this understandable interest in, you might even say, yearning for additional information about the immune system and how to positively impact that, not only by patients, their families, but by the medical community. And in fact, as you see on this slide, there are writings that go back to the 18th century about how individuals talked about cancer and about infection and what can one do to somehow help cause that cancer to regress. And in fact, the well-known author Chekhov, who was a physician, actually wrote about this in some of his writings, sort of talks about that kind of thought process. And if we go back literally into the medical literature more than 100 years ago, an individual at that point, Dr. Cooley, who for decades and decades was considered sort of a nut, described the relationship between infection and potentially literally sort of giving, we use Coley's toxin, but it was really the idea that you could stimulate the immune system locally by this injection, which was basically, bacteria, to stimulate that person's immune system with cancer to cause regression. And he described cases like this. It wasn't understood. Obviously, we didn't have antibiotics at the time. It wasn't necessarily a very smart thing to do. But the fact is that even back 100 years ago, there were those kinds of conversations in the medical literature. And then we, closer to the current time, there's actually in the days when we now had X-rays, before the days of CAT scans and MRIs, but we certainly had X-rays where one could document, and you could actually read some of the old literature today, where patients who had infections following operations, and the classic would be the patient with lung cancer, and because you could take an X-ray of the lung, just a regular chest X-ray, and demonstrate there was a mass, and then a patient after the operation might have had the term is used, empyema, an infection of the lining, and you could see this infection. And lo and behold, over a period of time, some of these masses actually shrank. The cancers, you knew they were cancer, they shrank. So that wow, again, there was no anti-cancer therapy. There was something about the immune systems that was being stimulated in that patient by this infection that caused regression of cancers. And then further into more recent times, there are anecdotal, I emphasize case reports of patients who had resection of a local cancer mass. Most of these experiences have been in melanoma and kidney cancer, again emphasizing, I'm talking about rare reports, where if one took out the primary cancer, areas that were never touched by surgery or any other approach, there was regression of those lesions. Again, the idea was, well, something happened within the body. Maybe by taking out this mass, you got rid of some suppressive factors that somehow allowed the immune system to favorably impact the residual metastatic cancer. Again, all of this is in the literature. All of this is happening over a period of many decades. So there's information was out there, and interest in trying to figure out how to harness what appeared to be going on that was quite real. I mean, again, when we get into the era where one has x-rays and you can look at these x-rays and you can see that, this isn't somebody hoping that it happened. You could actually measure it. In general, obviously, what I'm describing here are rare and also short-lived, meaning we're not talking about cures, although I would never say that's impossible, but, clear regressions of cancers that you can measure, you can see, that might happen over a period of weeks and then may last a period of months, but very real. Question is, how do you harness that? Other parts of this historical perspective is that it has been known for long periods of time that cancers could occur in a site where there was previous infection and inflammation. One of the classic descriptions in the cancer literature is in lung cancer, where an individual, non-smoker now, because obviously if you're dealing with a smoker, we say, well, we know why that patient had cancer, they smoked. But you could see cancers in non-smokers with no other known risk factors. And an individual would develop a cancer. And then that patient might have had an x-ray taken 10, 20, 30 years before. And if you go back and look at some of those x-rays, and again, everything I'm talking about is uncommon events, but yet well documented. Situation where someone saw in that x-ray not a cancer, but the term that is often used is a scar, meaning this person had a previous infection of some kind. Often it was a bacterial infection. It could have even been tuberculosis. We're going back to now, decades ago, or a fungal infection. And yes, the body was able to control the infection because it didn't spread, but there continued to be inflammation, something going on at that site that several decades later, something lost, the control was lost, something was controlling all this, it was lost, and a cancer developed. Again, not clear what was happening here, but raising the question that somehow the immune system might have been controlling this and then stopped controlling it. How do we turn this immune system on? And then we know, our researchers know, pathologists know, that if you actually do a biopsy, if you take out a cancer, you do a biopsy, and you see the cancer, we often see immune cells called lymphocytes. They're not cancer. I'm not talking about lymphomas. I'm talking about normal immune cells that are present within the tumor bed. You've done a biopsy, you see the cancer, and there are these immune cells. And the question is, what are they doing there? Is that a good thing? Is it a bad thing? Clearly, it hasn't eliminated the cancer, but they're there. So one of the questions that's come up is, maybe they're there, but they're not able to attack the cancer or recognize its foreignness. Why? Unknown until now. But the observation that these cells are there and may be important, if somehow we could manipulate them, has been in the minds of cancer researchers for a long period of time. And then we also have another aspect of the immune system that is relevant to cancer, and that is in the patient population where they're known to have a compromised immune system. Classic examples of this are individuals who have chronic immunosuppression that has been induced so that they do not reject a foreign tissue that has been placed in their body, such as a kidney or heart. And these individuals, this is accepted, incredibly powerfully good advances to be able to transplant kidneys, hearts, even livers, but these are foreign substances, foreign material, human material, and so that the immune system will not reject them, the immune system has to be suppressed, and we've seen cancers develop in those individuals. Again, saying, well, by suppressing the immune system, disallow cancer to form. And of course, I use it as an example, AIDS, the infection by the virus associated with AIDS, human immunodeficiency virus. It is not at all rare for these individuals who have a compromised immune system to develop different kinds of cancers. So with all that as a background, I'm going to discuss, again, briefly, sort of three aspects of immunotherapy. The first is the idea that you can immunize an individual. We use the term immunize, vaccinate, to stimulate the immune system with a protein, an antigen. And the examples I give here, which are well established, incredibly effective, are in the area of cancer prevention. So the idea is we are not talking about immunizing with a cancer antigen, a cancer substance, but with parts of an infectious pathogen that has been made safe. But we know that those particular infectious pathogens are critically important for the development, subsequent development of a cancer. And if you can immunize the host, the individual, against those infections before they develop the infection, then if they are exposed to those pathogens, they will be able to eliminate those pathogens such that they don't do their damage. And again, the two classic examples, incredibly important today in public health. The first is vaccination against the hepatitis virus. The hepatitis virus is extremely important for the development of hepatitis, which is liver infection, which, if becomes chronic, that can lead to scarring, fibrosis, inflammation, and the subsequent development of what is known as hepatocellular carcinoma, which is cancer of the liver, which worldwide is one of the most common cancers in the world. Not, fortunately, terribly common in the United States, but worldwide it's an enormously important public health problem which can be dramatically reduced by vaccination against the hepatitis virus. And the other critically important vaccine in this space, which is highly relevant, of course, in the female cancer arena, which is vaccination against HPV, human papillomavirus, which is responsible for far more than 99% of all cancers of the cervix. I think it's fair to say it's 100%. We rarely want to use that term in any aspect of medicine because you can always come up with a possible exception, but let's say it's greater than 99%. And we know that today that vaccination strategy could probably prevent in years to come somewhere between 80 and maybe even 90% of all carcinoma of the cervix. In addition to that, a substantial percentage of cancers in the head and neck region, the vulva, vagina, and anal region are also due to HPV infection, HPV incorporation into the normal DNA, and subsequent development of cancer. So here are two examples of an immunotherapy approach. Without any question, this is immunotherapy. It's to immunize, to vaccinate the host against these pathogens being responsible for cancer in this particular situation. Then we turn more, as we move forward, into the therapy of an established cancer. And the first approach is the one that has been studied most extensively until the recent times. And the obvious approach is to somehow boost the immune system, stimulate the immune system. And we have a number of examples. In fact, this has been a strategy that's been applied for the last 20, 30 plus years. And there are a variety of ways of approaching this. There is a drug known as interleukin-2, which is actually a commercially available drug. This has been a standard procedure used, for example, in melanoma and some kidney cancers. We also, and that by giving interleukin-2, that can stimulate the immune system with the idea that you would then stimulate the immune system to favorably impact a cancer. There are also strategies either by themselves or often with interleukin-2, is to take T cells, which are a critical component of the immune system. These are part of the lymphocytes. The lymphocytes are basically divided into several groups. Most commonly, when we talk about T cells and B cells, the T cells are responsible for the reactions that we see against cancers, the immune cells against cancers. The idea is you take the T cells out of a patient with cancer, and you would manipulate them to stimulate them in the laboratory setting, and then give them back to a patient with cancer, with the idea that that stimulated immune system will now attack the cancer and eliminate it. So there's been extensive work in this area. Unfortunately, there's actually been very limited success overall. There is highly provocative data, and a lot of the work here has been led by Dr. Steven Rosenberg and the National Cancer Institute, and he has published extensively in this effort over several decades. And in fact, there are some long-term survivors. And the most prominent experience here is in metastatic melanoma. When I say long-term, I'm talking about 5 and 10 years and longer, patients with very advanced disease who underwent these kinds of therapies, and in fact their cancer has gone into remission, and say 10 years later, it's not back, it's gone. But the percentage of patients has been very, very low. And these therapies, by stimulating the immune system, this is really toxic therapy overall. Finally, I simply note, to complete the group here, there's a lot of interest in what are called CAR T cells. This is a far more focused approach to stimulate these T cells than simply culturing them in a laboratory and making them all get active. These are really focused attempts. And to date, while this is a very exciting approach, it is far more in the hematologic malignancies rather than in what we call solid tumors like ovarian cancer, lung cancer, breast cancer, colon cancer, and often in the younger patient population, which is both important but also interesting. Why this seems to be more effective in the younger population, the pediatric population. Although again, to emphasize, this work has also been going on in the adult area, but it's primarily in the hematologic malignancies. So this has been that focus to stimulate the immune system. And now we come to what can only be described as paradigm change. Might have questioned in my mind that the Nobel Prize should be and will be awarded within the next several years for the work that I'm going to describe. And what I'm going to talk about now is brilliant work, and part of the thing that makes it so brilliant is it's so simple, and it explains so much. And there are those who, brain scientists, can do brilliant work, but the most brilliant are the ones that can really basically ask a question about things that everyone has taken for as a given and say, but wait a minute, there's something wrong with this. There may be another way of looking at it. And that's the only way to describe, in my opinion, the brilliance of the work of those who began to look at this question of inhibiting immune blockade. And there are a number of researchers in this area. Perhaps the most prominent, certainly the individual that I'm aware has been given a lot of credit for this, is a researcher by the name of Jim Allison, but there are others that were involved as well. And they basically took this entire historical perspective that I briefly described, what's going on here? Why do we see certain cancers respond but a small number? Why do we see all these lymphocytes that don't appear to be doing anything within the tumors? And he basically asked the question, perhaps, just perhaps, what's going on here is that it's not a problem of stimulating an immune system. The immune system has been stimulated just fine because the body has recognized something as foreign, but the cells are completely unable to respond to the foreignness. And the obvious explanation for this is as follows. If you cut yourself, you went outside and you unfortunately cut yourself on you fell and you cut your arm. Everybody knows what happens. There is a little bit of bleeding, there's redness, there's swelling, there's pus, again, if you don't clean the area. But even if you do clean the area, there's this swelling that goes on here, there's redness, and there's this reaction of the body. The immune system is turned on. This is your protection. But of course, the process also needs to have a way of being shut down. Because if there is no process to shut it down, you're just going to have this thing run rampant. You're going to have the inflammation continue to get bigger. You're going to have more cells that are going to go in there. What is the stop process? There has got to be a normal process of shutting the immune system down. That is the concept of checkpoints. So the immune system is stimulated, and at some point there's got to be something that blocks it, that stops it. We unfortunately know there are illnesses that occur where what I just described, doesn't happen well. Conditions like systemic lupus erythematosus, rheumatoid arthritis, a number of other conditions where the immune system is not under normal check and balance. There are things that stimulate it and it doesn't get shut down. So there's got to be these normal processes. And what Dr. Allison and his colleagues recognize is that some cancers are somehow able to, either directly or by substances they secrete, block the immune system at these checkpoints, just like the normal immune system is supposed to work. This does it in a setting where we don't want it to have that happen, but as far as the immune system is concerned, it's receiving a signal to shut down or to shut off. So what this work led to is the idea of developing inhibitors of the blockade. So checkpoints, which are normal, inhibitors. So we release the brake on the recognition of cancer being foreign. Cancer is foreign, but the cells that would normally recognize them as such aren't able to do so. We now have a number of drugs that I list here, and this is not meant to be complete in any way because we have new drugs added all the time, and there are different parts of the cascade that we're involved in here that, in fact, so CTLA4, PD1, PDL1 are all parts of this cascade, and they are basic. Those are the names for a variety of molecular locations, molecular targets, and drugs that have been developed in this space. So the idea here is you're going to release the blockade. You're going to inhibit the checkpoint. Now, today, there has been documented clinical efficacy of these strategies in multiple tumor types. I list on the slide: melanoma, lung cancer, kidney cancer, bladder cancer, head and neck cancer, chemotherapy refractory lymphomas. Today, there's now in lung cancer, frontline therapy, in fact, initial therapy of lung cancer would include these drugs. And there's also preliminary evidence for efficacy in a number of additional cancers, and with more trials on the way. And I'm going to talk about ovarian cancer just in a few moments. It's important to note that these particular drugs have unique toxicities that goes directly along with their mechanism of action. I just said you're releasing the immune system from this blockade. And therefore, this immune system, for reasons that obviously we're trying to learn, researchers are working on, the immune system can attack or influence or impair, whatever word you want to use, normal functioning. So we see gastrointestinal problems, colitis, diarrhea. We've seen diabetes. We've actually even seen some serious effects on the heart, inflammation of the heart, and also effects on the blood as well as on the lung. These are again, the normal immune system being now released, and for reasons that we're trying to figure out, are affecting normal tissue. And we also have, as we begin to look at combinations of the immunotherapies, which are increasingly effective against cancer by having several of these drugs together, we also run the risk of increasing side effects. So now, turning to ovarian cancer. There is a very solid rationale for the concept of immune targeting ovarian cancer. I mentioned here there are certain types of tumor-infiltrating T cells which have been shown to correlate with improved survival. So the presence of these immune cells within the tumor in ovarian cancer, if they're there, that's associated with a superior survival. We also know that there are immune suppressive T cells, I mentioned some stimulating, some suppressive, that are associated with, if they're present, are associated with inferior survival. We have considerable experimental, the term preclinical, before you get into patients, identification of potential antigens. I mentioned the antigens that are present in hepatitis, or antigens that are present in the HPV, and the idea of making antibodies to them to potentially stimulate the immune system. So there's been a lot of interest in that in ovarian cancer. Importantly, ovarian cancer itself, the patients with ovarian cancer are not inherently immunocompromised. Again, I mentioned back to the HIV story where we see a situation where it's hard to stimulate the immune system when we're actually compromising it because the virus is killing the immune cells, or in fact you're giving immunosuppressive drugs like lots of steroids to patients with kidney transplant. It's hard to stimulate that immune system. That's not what happens in ovarian cancer. And importantly, a relatively long survival and time away from chemotherapy, which again would potentially give the immune system the opportunity to express itself in a positive way because you're not suppressing it, or you don't need to for periods of time in the natural history of the malignancy. Again, this is all very general. It doesn't say anything about an individual patient. We're just talking about the rationale for immunotherapy in ovarian cancer. Now, what about the experience? Unfortunately, the experience to date in ovarian cancer is limited. I mentioned about Dr. Rosenberg. I mentioned about this cell therapy type work where you stimulate the immune system. There are very limited data in ovarian cancer. There's one trial that suggests a little bit of benefit, very little published on this, and part of the issue here does relate to the toxicities of many of these strategies. But the data that was available does certainly not suggest anything that's overwhelmingly positive with this approach. We have actually used antibody therapy, cetuximab and more prominently bevacizumab. Of course, bevacizumab is not directed at the cancer itself. It's an antibody directed at the blood vessels associated with ovarian cancer. And of course, bevacizumab has now become part of the standard of care strategy in ovarian cancer. It's important to mention that. There has been considerable trial effort in trying to stimulate the immune system in ovarian cancer patients, and published work has shown quite clearly that it is possible to have an immune response mounted, meaning you can measure antibodies created if you give somebody these drugs, these monoclonal antibodies. There's a reaction to that you can document. But in the randomized phase 3 trials conducted to date, and there are others that have been reported, and there are others that are certainly ongoing, there has been no evidence of an improvement in either time to disease progression, progression-free survival, or ovarian cancer, or overall survival. So while the rationale behind this immunization strategy as an immunotherapeutic approach is very strong, the evidence today is we don't see benefit. Now, one can easily argue, well, we just don't have we haven't been looking at the right antigens. We haven't been looking at the right molecules to develop an antibody to. All true, all possible. But where we are today is as follows. And then if you look at this question of stimulating the immune system, there's been a lot of work beyond just the adaptive T cells. There's been work with interferon, which is another stimulator of the immune system, given both intravenously and intraperitoneally. Interleukin-2, given either intravenously or intraperitoneally, and again, very little evidence of benefit. And then, of course, we turn to the question of checkpoint inhibitors, and to date, the evidence in ovarian cancer remains limited. There are clearly documented responses that have been reported in the peer-reviewed literature. One I noted in the slide, there was actually a patient who was reported who had advanced disease, who in the report had a response to the treatment with ipilimumab, which was the first drug looked at this place, one response lasting for longer than 4 years. I mean, those are the kinds of responses that have been seen in other tumor types that obviously we're hoping to see in ovarian cancer patient populations. And there are several trials ongoing that have not been reported specifically with CTLA-4 blockade. If you then look at the PD-1, PD-L1 experiences, again, several early phase 2 trials have been reported. Most of this is in abstract form. Very limited peer-reviewed publications to date. I note the ASCO meeting is coming up, and we may have more information reported within the next several weeks in the ovarian cancer arena, but this is where we are today. The general summary of the results, the side effect profile that has been observed in ovarian cancer is quite similar to that observed in other indications. In other words, there's no evidence for excessive toxicity or a new concern that has not been seen in the large number of trials that have already been conducted, and that's good news. Fortunately, to date, if you ask the fundamental question, are we seeing very high objective response rates to these drugs, given as single agents in ovarian cancer? The answer is no. So the objective response rate in patients, generally these are patients who have previously received standard therapies, and certainly no reports today in the frontline setting, which would be very hard to justify, and we wouldn't quite know how to interpret that. So the work has really been done in the platinum-resistant patient population with objective response rates of somewhere between 10 and 20%, which is similar to multiple chemotherapy drugs, including single-agent bevacizumab in this setting. Now, quite encouraging, is that some of these responses have lasted, in this population, have lasted long periods of time. And again, I can only give you long based upon the reports. I'd tell you if it was longer than 5 years if there were the reports, but we are talking about responses that are longer than 2 years because that's the duration of the follow-up we have. It doesn't mean that it won't be longer than 2 years. These are the trial data. But where we are today, as of today, is there are no objectively validated biomarkers. So if one were to ask, who are the 10 to 20% of patients who respond? Who are the patients that might have these long-term responses? Can we predict who they are based on something within the tumor today? As of today, the answer is no. I'm not saying that we won't have that information. By the way, that may be reports at ASCO, the ASCO meeting, but today, I cannot say, the literature doesn't say, if we can predict who will respond and how do we have a higher percentage of patients who might benefit from this therapy, or this strategy as we move forward. So if we ask the question of the future, it is likely that vaccine studies will continue. However, based on existing data, the value is questionable. Now, of course, once we have a positive trial of a vaccine approach, then this statement will simply go out the window. But until that occurs, it is hard to be optimistic beyond the preclinical suggestion there may be benefit if you look at the previously reported studies that also had interesting, favorable preclinical data that turned out to not be of value. So that's all one can say. One can obviously be hopeful, but on the basis of existing clinical data, it's hard to be optimistic that the next trial, looking at vaccine approach, will be a positive outcome. Immune stimulation, very limited data in other areas of cancer medicine. Clearly, immune stimulation has not been ignored or is not being ignored, but the benefits are not clear there, and they certainly are not clear in ovarian cancer. And of course, that leads us to the, again, continued exciting area of immune checkpoint blockade. Single agent therapy so far, as I said, the data are not overwhelming based on the response rate, but the duration of responses will be critical to evaluate. And put in bold on this slide, cannot emphasize the importance enough of determining a clinically valid biomarker. This could be the number of mutations present within a cancer or some other particular antigen that might suggest the patient population that could benefit. And clearly, one is looking at combination therapies, but as I mentioned, the concern there is with the added toxicities with combination. And finally, now I turn to opinion rather than, I might say, objective fact based upon where we are. What would be the mantra right now is phase 3 randomized trials in all tumor types, including ovarian cancer. And I really want to ask, I need to ask the question, why? Why randomized phase 3 trials? Why the mantra today? In the absence of a validated biomarker, does the observation of a response rate of 10 to 20% with several agents, which is quite similar to single anti-neoplastics in ovarian cancer, justify the time, the effort, cost, and the hundreds of patients to participate in these studies to see a number of years from now if we may have a small benefit? And if the 10 to 20% response rate is accurate, then if you look at all of the data we have on platinum-resistant ovarian cancers where we've done those trials over 30 to 40 years and have had negative studies, one might ask, is this the best way we should do it? Second question, should patients be required to simply wait for the results of these trials before they are given the opportunity to receive these agents? Can't we come up with a better trial paradigm to test these concepts far more quickly, far more efficiently, far more effectively to benefit patients? And in conclusion, when one considers the costs of such therapy and the toxicity, and importantly, the increasing number of therapeutic options that may be available, multiple drugs, multiple combinations, what is of greatest value? Got to demonstrate it. Because the goal here, perhaps overly simplified, but I think everyone understands, is to get the right drug or drugs to the right patient who might benefit and at the right time in their illness to have an optimal outcome. That's the goal. And it's, the goal is to do that increasingly rather than saying, oh, it's ovarian cancer, everybody has to be treated the same way, because we're recognizing that is no longer true. So at that point, I will stop, and I will be delighted to answer any questions that you might have.
Thank you so much, Dr. Markman. I just, before we want to start the Q&A, please keep in mind that not all questions that were submitted will be asked due to the clinical nature of some of them. And to the participants of the webinar, if you need additional support, please feel free to call the SHARE helpline, and we can, it will be answered by a trained survivor that can help you sort through any of the options and find resources to help you. Dr. Markman, we received many similar questions from women in advance of this webinar, and these are women who generally have had the gold standard frontline treatment of surgery and chemotherapy for ovarian, fallopian tube, or primary peritoneal cancers. But their cancers have come back in some cases. They're trying to make informed medical decisions about what's the most promising treatment to try next. What would you say to a woman who is trying to decide between immunotherapy trials, for example, those involving with PD-1 checkpoint inhibitors, or say the PARP inhibitors alone, or in combination with chemo or anti-genesis drugs?
Well, and I sort of alluded to that on my. It's a very important question. I mean, obviously, as you can imagine, that's the question I'm asked more than any other one.
Sure.
And it's an issue, but it's actually as someone who's been in this area now for almost 40 years, I am happy that we are at a point where we have these options. And that's the point. We have a lot of options, but now we get down to that individual patient and her family, and the question is, yeah, but what's the best option for me? My general answer is, obviously then you have to get down to that specifics of the patient, which of course we're not going to talk about here. But for example, if that the tumor has a BRCA mutation, or either germline or somatic, and obviously I know the group listening would understand that, and I don't have the time to go into details, but if there is a mutation, or there is strong evidence for abnormalities that would potentially suggest that a PARP inhibitor is of value, then certainly that would be where I would look first. I would also then, ask the question of, is there a biomarker that that is being hypothesized to be relevant in the particular drug or combination? And again, this is the patient asking the question, do we have evidence that my tumor has that present? So I sort of alluded to this in my comment, but I'll be more specific. It's an evolving area, but there is evidence that cancers, individual cancers, where there are lots of mutations, and again, this is a numerical issue. A tumor that it might have, and I'm just throwing out these numbers, but these are the kinds of numbers that people are talking about. An individual tumor where you can count the mutations, and there are 10 mutations per cell, versus a cell that might have 1,000 mutations per cell. That if there's 1,000 mutations per cell, it's more likely, it's all statistical probability, of responding to an immune therapy approach. And you might say, why? Well, the answer is, again, relatively simple. If you're going to release this blockade, the question is, what are these cells going to respond to? And if you have 1,000 things to potentially respond to, the statistical likelihood that one of those things or several of those things may be recognized as being foreign is going to be greater in that tumor with 1,000 than with 10. That's a overly simplified view of the world, but the data somehow supports that. So again, if an individual patient had the tumor evaluated, a number of labs to look at the tumor mutational burden, and it's high. And again, there are numbers that people have done the work on this, and you say, well, then I would say then that's a potential tumor that, maybe looking for a checkpoint inhibitor trial makes a lot of sense. And so but then you've got to get down to the specifics. So what the trial is, what kind of trial, what are the toxicities of the combination, where might it be available, etc. But it's absolutely critical that patients and their families ask the questions that, okay, there is a trial, this is great, but tell me how this is relevant to the extent that you can for me and my situation. What are the data about this that might be relevant in my situation, if it exists?
Okay, thank you. One participant asks, what causes recurrence after chemotherapy, and what's the best way to treat ovarian cancer after a first recurrence, and why?
Well, I wish we knew the answer to why the cancer occurs. And patients with ovarian cancer and their families know this journey, and it's a complicated one. The majority of patients with ovarian cancer do respond statistically. Obviously, that individual patient who responds is 100% for them, and for those that it doesn't, it's 0 for them. But the majority statistically respond, and yet today, for reasons we can speculate all we want, but we really don't know exactly, the majority of comes back. Some patients it comes back relatively quickly, within months. Some people it comes back much longer, many months to several years later. Why? We don't know. We're learning. As a general answer, though, as a very general answer, the longer that a patient has been away from therapy, that frontline therapy, the higher the probability they're going to respond to the same therapy given again. The tumor seems to maintain that sensitivity. It's And again, why that's the case, why does it come back, we simply don't know. And that's a critical part of the research that's ongoing. One can speculate, again, this is speculation, that the immune system has something to do with controlling the disease for periods of time, and then somehow the tumor is able to escape whatever that immune mechanism is, which is one of the reasons why there's a lot of interest in looking at these checkpoint inhibitors to, after, for example, primary chemotherapy, to try to stimulate the immune system's ability to monitor, you might say, and control whatever microscopic cells are still there. What I've just described is a theory. It's a rational theory, but it's one that's worthy of being tested.
Great, thank you. Does immunotherapy treatment sometimes include T-cell generation, bone marrow transplants, and supplementation with probiotics or antioxidants?
Well, the latter that you just mentioned are not really an immunotherapy approach. There's lots of theories about how one might stimulate various innate mechanisms, but probiotics and antioxidants have been theories that have been around for a while, and they're still there, but they're not directly tied to what I've been describing. You mentioned the question that relates to the T cells. That is part of the idea of stimulating the immune system. Bone marrow transplantation, high-dose chemotherapy bone marrow transplantation has actually been looked at in the past in ovarian cancer. It's obviously a very effective therapy in strategy in certain hematologic malignancies, even, quite frankly, in germ cell tumors of males and females. But it does not appear to be effective in ovarian cancer. So, but again, the first part of the question is the T cells. That is, in fact, this stimulation I was referring to, which does not appear to date to be a terribly promising approach, at least not with the strategies that have been looked at over the number of years. It doesn't mean that new strategies in the future to stimulate the immune system in ovarian cancer won't be effective.
Got it. Okay. In your experience, Dr. Markman, how successful is the PARP inhibitor Rubraca? Did I say that right? Rubraca. And how severe are the side effects?
Well, that's not an immune therapy approach. Rucaparib is one of several currently FDA-approved medications in the United States for the management of ovarian cancer. Niraparib and olaparib and rucaparib are three different drugs, different indications. All of them seem to be quite active and quite useful in the settings in which they've been tested and approved, and they have varying side effects, but they're going to vary from individual patients, and obviously beyond that I really can't say any more. Those are conversations that individual patients have to have with their doctors. The advantage of these agents, of course, is that they are oral, taken at home, and they seem to be very active in the population of women whose tumor has a BRCA mutation, which of course includes those individuals who have a germline BRCA mutation, which means that it's in all of their cells from birth, and also in the tumor cells, or where there's mutation just in the tumor itself, but not in the germline. And there is evidence that there are other abnormalities within tumor cells. Again, the time would not permit me to go over in details, but there are other abnormalities, not just BRCA, which suggest that a tumor, a cancer, an ovarian cancer, would be sensitive to this class of drugs. And that includes the most poorly differentiated types of cancer. A poorly differentiated serous cancer of the ovary seemed as a group to be responsive, just like they're responsive to platinum agents, they seem to be responsive to platinum agents. Again, my statement I just made is very general. The specific indications today are, one needs to look at both the FDA indications, but also discuss what makes most sense for the individual patient, and emphasize there are 3 PARP inhibitors, different drugs that are commercially available in the United States. So conversations with an individual's oncologist, gynecological oncologist, medical oncologist are important.
Okay, thank you. Just the last question. If anybody else has any questions, please submit them now. The last question, why is the response rate to immunotherapy so low, 10 to 20% within ovarian cancer, and how does this compare with other cancers?
Well, that's a $64 billion question. It's unknown. In no tumor type is it 100%. And so even where we're talking about really impressive results, and there are some really impressive results, we may be talking about 50, 60, 70% of patients, which is, you know, again, I emphasize that only to put this in perspective. There's no magic bullet here where this therapy eliminates, everybody responds to, and even when you have those kinds of responses, 60, 70%, they don't always last that long. The response rates are, you know, are in general much lower. What makes the response rates to immunotherapy so impressive, these checkpoint inhibitors so impressive often, is not even necessarily the objective response rate itself, but some of the durations of these responses, which are not measured in months, but maybe measured in years, maybe even permanently, but we don't have data on that. It is true, however, that the response rate of 10 to 20% ovarian cancer is on the low end of, you know, where one might consider this to be particularly promising. But again, what I would emphasize is we're just learning. And just because we see much higher response rates in melanoma or some of the lymphomas or even a lung cancer doesn't mean that we can't figure out how to get either those kinds of response rates in ovarian cancer, or even if it's only 10 to 20%, having those 10 to 20% being much longer responses. The key here is figuring out the biomarkers. What is it? Well, figuring out the biomarkers so we can figure out who's going to respond and why, and then coming up with alternative strategies for this. So, for example, what I'm referring to is single agent therapy. It may be a combination of several of these drugs will be much more effective. It may be that if we give it in a setting where we're not dealing with platinum-resistant disease, but maybe in the maintenance strategy after first-line and second-line therapy, maybe the drugs will be more effective. These are all maybes. All we know today is the 10 to 20% response rate in generally in the platinum-resistant population. We may see very different response rates with different combinations or if given in different settings. But that is going to take time and is going to take research, which again is why I emphasize we've got to figure out a way of studying all of these approaches far more rapidly than we're doing it now. Far, far more rapidly.
Thank you, I agree. One last question. Is there any benefit to having the HPV vaccine when older to reduce the possibility of cervical and other cancers?
Yeah, the answer is obviously it doesn't have anything directly to do with immunotherapy, although I did bring it up. The answer is absolutely yes. The only comment that I would make is clearly the FDA indications are based on the population, but if a woman would know that she's not either been exposed to HPV or she doesn't have HPV antibodies, and she's, you know, the answer is absolutely yes. There's nothing negative at all about getting vaccination later in life, particularly if she has not had prior exposure to HPV.
Great. Thank you so much. Thank you so much for an informative program, and thanks to everybody for participating. Please, as soon as we close out the webinar, an evaluation will pop up on your screen. Just give it 1 minute, and please do fill it out. It really helps us make sure to plan programs that will be relevant and needed for our population. Thank you again, Dr. Markman. And,
my pleasure.
Thank you. And this will be recorded and posted on our website soon.